Penile rehabilitation after treatment for prostate cancer. If you've undergone treatment for prostate cancer, your sexual function can change dramatically. You may encounter problems that can be disturbing and frustrating. Our feeling is that you have a greater chance of getting back to your pre-treatment function if penile rehabilitation begins soon after surgery. In fact, there appears to be a short window of time following surgery where rehabilitation can prevent long-term erectile dysfunction. If it is possible to see a specialist before surgery, you can create a rehabilitation plan that will improve your chances of returning to pre-surgery sexual activity. The more you know, the better your recovery will be. What changes in sexual function may occur after a prostatectomy? Erectile dysfunction. In the short term, all men will have their share of erectile dysfunction. There's a wide range, 20 to 90%, of long-term post-surgical erectile dysfunction. But it seems that the closer we analyze the cases of these men, the higher the incidence. There's not that much difference between the erectile function of men undergoing surgery and those undergoing radiation. However, clearly, the radiation takes longer to damage erectile function. Penile length shortening. Right after the surgery, many men notice that their penis has shortened or retracted more into their body. This is not thought to be from actual shortening of the penis, because it certainly doesn't happen from the surgery. Then what causes it? When your body is under stress, it sends out signals through part of your nervous system called the sympathetic system. This is often called the fight or flight response. The sympathetic nervous system is responsible for all of the symptoms that you have when you're anxious or angry. For example, sweating, increased heart rate, sweaty palms. In the penis, this causes the smooth muscle in your erection chambers to contract, which is why anxiety is not good for erections. This makes your penis retract. As your body heals, this acute shortening of your penis should improve. But you may notice permanent shortening of the penis after surgery, and this might be quite significant. The penis, in its flaccid, unerect state, has very little oxygen. With erections, fresh oxygenated blood is brought into the penis. If you are not getting erections, either with sleeping, nocturnal erections, or with sexual excitement, then you are not getting enough blood and ultimately not enough oxygen into the penis. This results in fibrosis of the penis, loss of flexibility, and ultimately shortening of the penis. This fibrosis may be very difficult or impossible to reverse. That's why it's important to try to avoid fibrosis by initiating regular erections as soon as possible after surgery. Peyronie's disease. We don't know all the reasons, but up to 10% of men will develop scar tissue of the penile sheath after prostatectomy. This may lead to penile curvature when erect, penile pain, and worsening erectile dysfunction. This seems to occur more frequently in younger men. Ejaculation. The prostate and the seminal vesicles, which produce much of the semen, will be removed at the time of the surgery. The vas deferens, the tubes that carry the sperm, will be interrupted, just like in a vasectomy. Much of the production of the semen is stopped and the delivery of the rest of it is blocked. This does not mean that you cannot have an orgasm, but you will not ejaculate. This often takes getting used to, but is, in and of itself, not a problem. However, you may find that when you are sexually excited, sticky fluid continues to come out of the tip of the penis as it did before your surgery. This is the pre-ejaculate, or in popular vernacular, pre-cum. It is produced by the glands that line the urethra when a man is sexually excited. There are not sperm in the pre-ejaculate after a prostatectomy, so it will not initiate a conception in your partner. Of course, this means that you cannot achieve a conception with a partner through intercourse. If you think there is a chance you will want children in the future, it is worthwhile to bank your sperm prior to the surgery. Your body collects the sperm in ducts, and thus there are usually more than 60 million sperm in an ejaculation. These sperm, if of adequate number and quality, could be used to put into a partner's uterus, a process called intrauterine inseminations, IUI, to attempt a conception. If you do not bank sperm preoperatively, but decide later you would like a child, you are still usually making sperm. This is because even if your sperm ducts are blocked, you continue to make sperm but cannot get them out through ejaculation. Sperm can be harvested from the testes or its collecting ducts. However, because the body is not concentrating them naturally, only a few are retrieved. They will only be usable in a process called IVF/ICSI. This involves taking the eggs out of a woman's body and then injecting a single moving sperm into each egg. This is, of course, more expensive and invasive than using sperm that had been frozen prior to your surgery. Orgasm changes. You may notice that following surgery, it's more difficult to achieve orgasm or its intensity may be diminished. Sometimes there's pain with orgasm, typically in the tip of the penis. With time and treatment, this will usually improve, as will the intensity of your orgasms. Leakage of urine with orgasm. You may have some urinary leakage with orgasm after your prostatectomy. However, most of the time, this will resolve during the first year. For about 20% of men, this will continue, but it can be managed. The easiest thing is to use a condom. If this is not successful, then a specialized tourniquet can be placed around the penis. Medications can be tried to stop the urinary leakage. Mechanism of ED after prostatectomy. Nerve damage. You should know about something called radical prostatectomy, which spares the nerves and is the current standard of care. However, due to certain characteristics of the cancer, either known before the surgery or discovered at the time of surgery, this is not always possible. The ultimate goal of surgery is to make sure that all of the cancer is removed. If the cancer involves the nerves, then they cannot be spared. These nerves are the ones that stimulate the penis, and they must be intact for you to get erections on your own. If these nerves need to be taken, or are taken by mistake, this does not mean that you will not be able to get erections with treatment, but you will not be able to get them on your own. Even in a nerve-sparing prostatectomy, the nerves may be stretched, damaged, or traumatized, so you might find that they are temporarily or permanently injured, even if spared. Studies have shown that the nerves are not arranged in neat little bundles, but surround the prostate. Because of this, a very careful technique must be used in order to spare as many of them as possible. Damage to the penile blood supply. A good blood supply is necessary to get a good erection. In general, the blood supply to the penis is spared during a typical prostatectomy. However, many men have unusual blood vessels called accessory pudendal arteries. These may supply much or even most of the blood flow to the penis. If these are interrupted by the surgery, there may be inadequate blood flow. Inability of the penis to trap blood, venous leakage. In order to get an erection, you have to get the blood into your penis, and it needs to stay there. The analogy we use for our patients is a bathtub. You have to turn on the water and put in the stopper in order to fill the tub. If the penis does not get regular oxygenation by getting erections, the tissue that traps the blood does not get enough oxygen over time and is damaged. This causes it to become less pliable and it cannot store the blood. What happens is that even if an adequate amount of blood gets into the penis, it cannot be stored adequately, and you will not be able to get and/or maintain a rigid erection. What factors affect penile rehabilitation after a prostatectomy? What was your sexual function like before surgery? That's an important factor. Most men who are having a prostatectomy are not having erections of the quality and duration that they had when they were younger. Many are already encountering erectile dysfunction, which may or may not have responded to oral medications. Since a prostatectomy necessarily diminishes the quality of the erections a man will have after the surgery, you have to consider what your starting point was when looking at your prognosis. The surgical technique is one of the most important factors. If the nerves are not spared, it's impossible to regain spontaneous erections, though remember, there are always ways to treat every man with erectile dysfunction. You have to realize when you take into account all of the differences between patient risk factors, the most important factor is the skill of the individual surgeon. As a surgeon himself, and since he specializes only in sexual dysfunction and male infertility and has not done a prostatectomy since his training, Dr. Werner advises that you should pick the surgeon, not the technique. Treatment: a comprehensive penile rehabilitation program. Why is a penile rehabilitation program needed? One of the most important factors in determining what the quality of your post-operative erections will be is your commitment to rehabilitating your penis. A recent study of men who committed to a program of penile rehabilitation showed that 52% of them recovered unassisted functional erections, i.e., they could get and maintain an erection strong enough for penetration without medication. This compared to a recovery of 19% in the group who did not participate in rehabilitation. In the same study, 64% versus 24% responded adequately to Viagra, and 95% versus 76% responded to injections. When should the treatment program be put into place? In a perfect world, treatment of your potential erectile dysfunction would begin before your treatment for prostate cancer. The ideal is for this treatment to be performed by a urologist specializing in erectile dysfunction. Oncologic urologists, those specializing in urologic cancers like prostate cancer, will often not have the same level of expertise with erectile dysfunction as they have with cancer. Your treatment would include a thorough assessment of your current sexual function with you and your partner, if you have one. Studies have conclusively shown that the sooner you start treatment after the surgery, the faster your recovery, and the better the final results will ultimately be. The incidence of post-surgical venous leakage, as described above, increases as the amount of time without treatment increases, 30% at 8 months and 50% at 12 months. Who should put the rehabilitation program into place? You'd have a specialist do that, usually mapping out a comprehensive treatment program. Your specialist should have the expertise, time, and interest in maximizing your recovery. What are the different parts of the penile rehabilitation program? Oral medications. This would include preoperative use of a PDE5 inhibitor, i.e. Viagra, Levitra, or Cialis, which is thought to protect the lining of the blood vessels. There are studies that show that these medicines can actually increase the amount of smooth, involuntary muscle in the penis. This muscle is responsible for trapping the blood during an erection. There are 3 PDE5 inhibitors available at this point, though several more are being developed. We recommend Cialis to our patients because it is the longest acting of them. With this, there are constantly reasonable blood levels of the medicine in your bloodstream, which is preferable for a protective medication. Cialis is approved for daily use and is usually available through a pharmacy plan in the 5 mg daily dose. However, depending on your medical condition and the availability of the medication to you, 10 mg per day can also be used. Ideally, the Cialis is continued throughout your postoperative period. You will have to ask your surgeon when or if he wants you to stop it preoperatively, and when you can restart it postoperatively. Modalities other than oral medications. Then again, if you are not getting rigid erections adequate enough for penetration using a PDE5 inhibitor alone, then we'd advise more aggressive treatment starting 1 month after surgery. You will be encouraged to use a treatment that gives you good erections, adequate for penetration, while your penis is recovering. These may include vacuum erection devices, penile extension devices, intraurethral alprostadil, or penile injections. One of the options available for the treatment of erectile dysfunction is to self-inject medication into your penis. This often sounds scary to the patient and not particularly appealing. However, in reality, the technique does not involve a traditional syringe and does not hurt. Often, once a patient understands the reality of his treatment, he is willing to consider this highly popular and effective treatment technique. It works like this. The medication goes into the penis with a device that's similar to the ones used by diabetics. The use of this device is one of the most important ways to make this technique palatable to men. A disposable syringe is placed on the injector, the device is placed against the side of the penis, and you press a button. A spring pushes a very thin needle into the penis and, at the same time, pushes the medication into the penis. Most men would tell you that the, quote, injection doesn't hurt. They describe it as either painless or as if they had been flicked with a rubber band. The injection is extremely quick and uses a very fine needle, usually a 29 or 30 gauge. And since the side of the penis doesn't have many pain receptors, there is little sensation. The three most common medications used for injections are papaverine, phentolamine, and prostaglandin E1. All three act by relaxing the smooth muscles and causing the arteries to dilate. This activates the trapping mechanism. Prostaglandin E1 received FDA approval in 1996 for erectile dysfunction treatment. It is currently marketed and available in prescription plans under two brand names, Carajet Impulse and Edix. The different medications have different characteristics. The papaverine and phentolamine come in a liquid, do not need to be refrigerated, and have the least discomfort associated with them. Prostaglandin E1 is a powder that is mixed with a fluid prior to use. This is due to the fact that it is stable as a powder at room temperature but not as a liquid. Prostaglandin E1 can cause some ache. Although it is not medically concerning, it can be uncomfortable. However, in most cases, the discomfort is short-lived. Discomfort is experienced by approximately 20% of patients and is most common in patients who have neurological erectile dysfunction, such as diabetes or post-radical prostatectomy. You might want to know about possible complications from the injections. They are the development of scar tissue and the possibility of a prolonged erection, but those risks are significantly minimized when you are seeing a physician who is very experienced with this treatment option and the appropriate dosing levels. The risk of scarring is greatly reduced if the penis is compressed for 5 minutes after the injection and the site of the injection is varied. Penile injections were developed approximately 30 years ago and were the second method developed for the treatment of erectile dysfunction. The first treatment method was surgical and involved the insertion of a penile implant. Our experience with injectable medication tells us that many men are successfully treated this way. Their erections are often much stronger and more reliable than those from the oral medications. In some ways, the injection is a more spontaneous solution for treating impotence, since it can be used right before a sexual encounter. With foreplay and the medication, the individual gets a good, strong erection. On top of that is this news. Studies suggest that men who use the injections on a regular basis have a high likelihood of seeing improvements in their spontaneous erections. Conclusion. We'd like you to be aware that it takes a full 24 months after surgery to get the best indication of where you are going to end up. It's crucial during that time to stay motivated and on schedule. Remember, though, that not only are you rehabilitating your penis, you're also making sure that you have a satisfying sex life while waiting for things to improve. Our best advice is to seek help from an expert even before your surgery to maximize the speed of your recovery and maximize your chances of ending up with the best erections possible after you have completely healed.